Hello, good morning, everybody. Hi, welcome. Hello, everybody. So glad you could be here. Take a moment and say hi in the chat. We'd love to hear where you're from. Good morning, everybody. Thank you for joining us. We'll get started in just a minute. Hello, everybody. Hey, look, we got some folks here. St. Bernardine, Tulare County, welcome. Hi, Megan, Moderna. Hi, Latoya. Thank you all for being here. Wonderful. Hi, Liz, Washington State. Wonderful. Glad you could join us here. All right, well, let's go ahead and get started. We've got a great group today. Thank you so much for joining us. My name is Amy Lundstone, and I'm a project manager here at California Bridge. We're really excited about today's topic. It's the fourth in our Innovation in Nursing series, Lessons Learned, Ensuring High Quality Care in Every California Hospital. So if you have any questions during this presentation, please feel free to put them into the chat. There'll be an opportunity for questions later. This session is being recorded and closed captioning is available. CEUs are available for those who are interested in completing the post-event survey. Today, we have a panel of nurses who have been instrumental in implementing this work at their sites. I'm really excited to introduce Tana and turn this over to her. Tana?
Thank you, Amy. I just want to echo her thoughts, and we're excited to spend this time with you talking about what lessons we have learned through implementing medication for addiction treatment programs in our own hospitals. We have nurses from a variety of perspectives joining us today, so I'm really excited about what we can learn from each other. So let me introduce myself first, and then I'll have each of the panelists introduce themselves. My name is Tana Brooks, and I am a nurse advisor for the California Bridge program. And I also am currently practicing as a charge nurse in an emergency department. So I get to see the work firsthand and then also work on the backhand side with the California Bridge program. All right, so I'm going to have each of the panelists introduce themselves. Let's start with Sherry. Sherry, do you mind introducing yourself and just telling us how you are involved with this work?
Yes, well, welcome everybody and my fellow nurses. It's neat to be here with you. Thank you for all you do. I'm Sherry Cisneros. I am the SUN Program Director for California Bridge, but I also happen to be a registered nurse. So I'm really excited to switch hats today and play my registered nurse hat with you guys.
Perfect, thank you. And then Jen?
Hi, everyone. My name is Jen Deno. I'm the clinical educator for Sutter Medical Center Sacramento Emergency Department. We're a large emergency department in downtown Sacramento, and we implemented our program about 3 years ago.
Thank you. And lastly, Christine.
Hi, I'm Christine. Thank you so much for having me, California Bridge. I really appreciate it. I work here at Marshall Medical Birth Center in Placerville, California. I'm a registered nurse here for over 20 years, working as an L&D, postpartum, nursery, and I'm the lead lactation consultant here. But I also oversee our substance use protocols and procedures with our pregnant community and their families. So that's why I'm here, to share my experience.
Awesome. Thank you so much, Christine. And thank you all for joining us today. Okay, so we're going to review our course objectives really quickly here. We're going to work through any barriers faced by nurses when treating opioid use disorders, gain knowledge of best practices in opioid use disorder treatment, and evaluate the integration of evidence-based substance use treatment in a variety of settings. Just a reminder, California Bridge is a program of the Public Health Institute, and none of the panelists have any disclosures to make today. Our goal with California Bridge is to provide 24/7 access to high quality treatment of substance use disorders in all of California hospitals by 2025. And as of now, we have 188 hospitals who have implemented the Bridge model. So that's very exciting. We're just going to jump through these first couple slides real quick, and then we'll jump into some questions real quickly here. All right. This is our impact to date. This is showing from April 2019 through June 2021. And you can see how many patients that we have interacted with and connected with treatment, which is a really incredible thing to see. We're very excited about that. All right, so a very brief review of the California Bridge model. This is something that you have probably seen before, but I'm just going to review it really quickly for us. So the first is low barrier treatment. So that's finding ways to mitigate those barriers that patients face when they are trying to get connected with treatment. So a patient shows up in the emergency department suffering from opioid withdrawal. How can we get them connected with care, get them treatment as promptly as possible without a lot of barriers? The next is a connection to care and community. So that's finding those resources and connecting the patient with those resources that will help them be successful in the long term. And then the last is a culture of harm reduction. So finding those ways to reduce harm for patients wherever they're at in their stage of treatment, recognizing them as a person first, showing them value as a person. All right, and then one of the core concepts or themes that I think that is important to remember as we begin this conversation is to remember that addiction is not a moral failing. This is a chronic disease that requires medical treatment. So if we approach this from a similar way that we approach the management of diabetes or hypertension or some other longer term chronic disease, that's what we're advocating for, and that's the approach that works best for patients. That's the evidence-based way to approach this. Okay, and then just to review person first language. So when we use terms that recognize the person first, rather than the behavior, it shows that person value and respect. And we're all learning and growing, so we're all going to make every effort to do this as panelists today, but just remember that we're all people and learning and growing in our own practices. So what we're is using terms like a person who uses drugs, a person with a substance use disorder, rather than using those terms that are somewhat stigmatizing like addict or user or junkie. So that those terms help us remember that a person is a person first and a behavior is something that can be changed. All right, with that, we are going to jump into some questions, and we're going to start with the topic of nursing education and engaging nurses. So I'm going to call on Jen first. Jen, tell us about how you have engaged nurses in the implementation of your medication for addiction treatment program, and how have you provided education to them?
Hi, everyone. I hope you can't hear all the noise in the background here. I back up to a bathroom and they're changing the paper towels. Anyway, I'm just so glad to see people from all over California that are mentioning where they're from in the chat. But we started about 3 years ago, as I had mentioned. Dr. Kevin Jens was one of our physicians in the emergency department and really wanted to get this program going. So he and I met initially, and then we pulled in pharmacy and then our social workers. I think we also worked with case management and of course our management team, and then the hospital administration to get this all started. So we had a few meetings to get things in place. Of course, there's a lot of pharmacy, work in the background with the DEA and the X waivers and all of that. But once we were ready, we wanted to roll it out in such a way to really address what she had just said there about it being a chronic illness and not something that, we've really gotten very jaded about with some of these patients. So when I built my education that we did at a staff meeting, and we actually pulled in pharmacy and our social workers to the same meeting and physicians from the department, so that everyone was really getting the same message and then was able to discuss, potential issues once we got it rolling. I included the very basics of pathophysiology with how the medication works as compared with how opioids work on the body systems. And then I put in a lot of education about trauma-informed care, which was not something our nurses really had ever heard about before, which really, takes us back to the very basics of, how we take care of patients, thinking about them, like she said, as a person first. And so that's where we started from.
Awesome. So did you have the whole pharmacy and social work and physician teams in the room with your nurses, or?
We had quite a few. We run 3 staff meetings every couple months, at least during that time. Good that it was before COVID, because trying to do that all on Zoom hasn't been as successful. But yes, we had them all in the room at the same time. And then of course there were many discussions, in our department.
Wow, that's amazing that you got everyone there together in the same room. to have those conversations. That's really cool. All right. Do any of the other panelists have anything that they want to add to talking about nursing education and engaging nurses?
Hi, yes, I'd love to just mention that, you know, I come from a big urban city hospital, Pomona Valley, for those who know, in Southern California. It is a trauma center. So having over 200 nurses just in our emergency room, we really had to coordinate services. And one way is we provided a mandatory, thanks to administration, a mandatory training learning module on our learning LMS system, which was so helpful to get the word out. So definitely getting the buy-in from administration to just start small. We just started with our ED, our 600 nurses for the hospital. We implemented slowly through med surge. Then we went to telemetry and then ICU. So ours was kind of calculated and strategized to where patients, first of all, are mostly discharged, because that's the follow-up care that we wanted to provide too.
Awesome. Thank you for sharing. That's really neat that you were able to put it on your LMS. Let's see, Dawn wants to know, what was the learning module that was used? Is that something you created internally?
Yeah, we created our own because it was specific even to how they order, our resources. So we really homegrown our learning because we did links to our website. So everything was really calculated. So that way the nurse, when they did learn, go on to the LMS, they knew our policy was there. Everything was already in one place. So we just definitely focused on our processes for our hospital. But yes, we made it.
Gotcha. Thank you. Okay, we're going to move to our next topic. We're going to talk about some barriers and challenges that we have faced. Christine, tell us about some of the challenges that you have faced with treating patients with substance use disorder in your department, and how did your team handle it?
Okay, thank you, Tana. I'd like to start by going back a few years prior to California Bridge here at our hospital. We worked with pregnant moms, and we began collecting data. We have almost about 18% of our moms use some sort of substance during their pregnancy. And it is a challenge because we have a baby involved, and of course the family, and I think everybody has that challenge of the family. But what was happening was buprenorphine started coming into the picture. So we were seeing moms that were coming in using buprenorphine, and the physicians had really no idea at the time how to deal with how to prescribe. Even what they were doing was they were considering them high risk and sending them down the hill. So we'd lose our moms in the community. Basically, they'd have to deliver down the hill. So what happened after that was UCD had an opiate use disorder collaborative that we joined with our physicians, and actually one champion OB and one champion pediatrician. And that was eye-opening. We had a perinatologist talk about exactly what Jen was just talking about, as far as what is buprenorphine, how does it work, how does that relate to having the baby and trying to keep these babies together. So we started working on developing protocols. We were already had our referral process. We had CPS, not CPS, but they're involved also, but public health and other collaboratives that would help us with resources, but we needed the physicians on board, and it took a bit. And then once California Bridge came, has it been 4 years now, Tana? I'm not sure.
Maybe 2 or 3 years.
And all of a sudden we had the physicians being ex-waivered, and we have a CARES program that's the substance use clinic here, and so they started using that. So they started collaborating with that, being able to work with all of us, and that became challenging also for the nurses, because everybody was kind of scared of drug a little bit and how it worked and the dosages and everything like that. So I would say that was a huge barrier in the beginning, but as our physicians started to be more educated, get their X waiver, start using their resources, then we were able to make protocols about referrals and start to teach the RNs here, which I'm a big part of, to, when you guys were talking about the learning about how to relate to patients during this time. We have a lot more to go. I think our nurses do really well overall, but I think I can't wait till we do lots and lots of more of this training for our RNs. So that's where the challenges came, but I think we've come a long way. And then now we've had even more challenges because we lost a lot of our OBs. So we have all brand new docs. And so we're kind of in this whole new, how life is, it changes, you get kind of going and you think you're on a good path. And then we got all new docs who have nothing, they just really don't know what to do. So we're addressing that. We're on committees. We've got our navigator up here helping us and our social services and stuff. But that's been our major challenges.
Well, thank you for sharing. What do you think alleviated that fear for the nurses in giving the medication and or keeping the babies who were delivered by moms on buprenorphine rather than sending them down to more specialized care? What do you think helped alleviate that fear?
I think two things that really helped alleviate it is when we had not only our OB champion that was keeping those pregnant mamas, and but for them to once the pediatrician was on board, our head pediatrician, and we started doing the NAS, which is the neonatal abstinence syndrome protocol for Eat, Sleep, and Console. So we had a non-pharmacological approach to keeping these moms and babies together, because a baby would be born and they go through withdrawals after buprenorphine and other, of course, active use also. But we changed it to the Eat, Sleep, and Console. So we are being able to keep over 70% of our babies now with their mom and discharge them together. So once the nurses started to see that the physicians were on board, of course they had questions about dosing and all that. And that was when I had to be, educating myself, which I'm still learning every single day. But that's where they started to have the confidence, and they got to see that, oh my gosh, we can really get these babies through their withdrawals and keep this family together. It was really wonderful to see. And then we started working with public health, and we started doing tours specially for a mama that's in treatment, and she's on buprenorphine, and she might feel like she might be stigmatized, or she might be looked upon as negative, and to see these moms look on their face when they just relax and say, come on in, we've got a really good program here set up. So we had new brochures and education for the patients. And so we're really working with other people in our community to help make them feel a lot more comfortable being there.
Wow, that's amazing. Thank you for sharing, Christine. Okay, we are going to jump to our next topic. We're going to talk about managing interdisciplinary relationships. Christine, I know that your team has come up with some creative ways to help patients be able to access the treatment they need. Can you tell us more about that? I know sometimes you don't have an X-waivered provider, or,
right. Especially like I said, now we have new physicians, almost completely across the board. So we don't have anybody X-waivered at this point. And so what we've been doing, and especially, we're on a small unit. We do 30, 35, 40 deliveries a month, unlike probably the bigger hospitals. They do a lot more. So we don't have as many resources, but using our Substance Use Navigator has been amazing. I'll give you an example of what happened yesterday. We had a physician who had no idea how to prescribe buprenorphine. And actually we call them locums, so temporary MDs that come in and help us until we can get a nice solid group. And so we had a doctor from down at the ED come up and actually guide him and help him to prescribe the medications that this patient really needed on the unit. So, so we have to use our resources. We have to use peers. We have to use the ED because Tana, you've been there for what, 2-3 years, and so you have all that experience behind you. And I feel like a little baby just kind of coming up, you know. And now we have a new set of education that we have to do. We have a ton of new RNs, baby RNs. So the teaching aspects is going to be, but they need to know where to go in these relationships. So we're trying to build the relationships as much as we can and be as creative as we can, because we're not here in the middle of the night. Tana, I don't know if you're here in the middle of the night. I'm not here in the middle of the night. We need to help knock shift, right? We need to help those moms to make sure that they don't go home on, you know, they need to be helped right away.
Yeah, well, that's really cool that you've been creative about like pulling, maybe there's an experienced physician in the ED or whatever that may be to help make sure that patients get the treatment they need if you don't have it in your department. That's really cool. All right, Jen, how have you navigated with Substance Use Navigator availability and collaborating with the nursing staff? So if the son isn't available, is there a process in place, or how have you navigated that?
We were lucky in the beginning that our son was actually someone who'd already worked here as a social worker and had the experience and background to take on the role, and then went for more training. So everyone already knew her because actually our social workers and case management have an office right in the emergency department. So they're out on the floor. We're interacting with them frequently. And then she does work pretty much like a 9-to-5 weekday schedule. So they can put in a referral for her to contact the patient even once they've been discharged. So I had gone through and reviewed our most recent cases, and I can see her notes almost every day on some of these patients that, you know, once they, like maybe she saw them in the ED, but then I can see notes where she's checked on them every day since they've been discharged, or that she reached out to them, like maybe if they had come in over the weekend. I can see some of her notes there throughout the week, and the connection that she's got with our local clinic here to get them into their therapy sessions.
Awesome. And Sherry, when a Substance Use Navigator is not available, do you have a process in place to help nurses connect patients with treatment, or how does that go?
What that is we have a text. So in our mandatory training, they're told the process, so they know that they can either, if there's a special instruction, they can call or text or email. For the most part, they'll say, hey, we put in a consult for you, and our follow-up is within 3 days, specifically if it's a holiday weekend or things like that. We also have coverage pretty much every day, 24/7 by texting. So we're fortunate that we have these, you know, robust follow-up. So that way our nurses never feel that they're left abandoned, because like Christine said, they don't even know how to pronounce buprenorphine, right? Right. They don't even know you know, what the correct dosage. So they know, definitely we have binders, but more than that, we have the buprenorphine protocol that explains everything. So they know the resources and where to get them. In the ED, we have team leads, we have charge nurses, because it is such a huge, you know, we could have a staff of 30 in our emergency room. So definitely the team leaders know where the binders are. We have pamphlets and my business cards, mine and because I still work as a substance use navigator, but our other substance use navigators, so they have cards that they can give immediately to the patient and tell them, you know, here's their number. But I think the best intervention was providing a text, because it's immediate. Hey, are you here? No, I'll be there tomorrow. Okay, I've got this patient. I'll leave everything for you. Okay, so it's, you know, the communication is a lot easier than to get on the phone, wait for somebody, they don't know who's going to answer. So texting really helped us with after hours, because even the night shift can text.
That's cool.
Yes.
Yeah, that's a neat program. I know what we do from the emergency department at Marshall is we have some standing appointments with the clinic, with the outpatient clinic. So if a patient is started on treatment at, like, I don't know, 5 or 6 p.m., on Monday, the patient can go to the clinic at 9 a.m. the next morning. And we already know that the clinic has a standing appointment for any referrals from us, which is a really neat relationship that we've built with those clinics, so that we can just tell the patient right there in the emergency department, hey, go here at 9 a.m. tomorrow, and they're going to connect you with your outpatient care. Christine, tell us a little bit about how you're currently working to manage those clinic relationships from the birth center.
Okay, so making sure I have just connected with your substance use committee. So that is just started. And then my relationship with ED, even through this California Bridge, through this program right here as we talk, this is my connecting with you. And then the more detail, I have my son, I have my substance use navigator, and she's going to help me to create some sort of workflow, so that if it is at night or if it's during the day, who do we call exactly? I love the text idea. I'm not sure, Tana, how that would work with us and the ED, but I've been to the CARES clinic and talked to the doctor there and made sure she knew, how to send a mom over, especially if she's just seeing somebody. So those relationships. The one thing that I'm working with the new physicians is when they come on board, there's an in-service right away. So this is what we do at this hospital. This is how we manage so far having a mom that's either active user on, and what her resources are, or she's on buprenorphine, and what we do after the baby comes, and how we use our NAS program, and how we keep these babies. And so that's been working, I think, pretty. It just started, like I said, but I think it's a good start. And then I also would like to sort of start relationships with the offices, the OB office staff itself, so that we're not, that stigmatism is just big. And so I would love to learn maybe something from here, or something that I can use to teach about that to not only our staff, but also the OB clinics. And I think that would be really helpful. And of course, our new docs.
Yeah, no, that's really cool. It's important to have the whole team involved in, and it's a process. We won't always be there all in, right when we want to, but it's a process of getting, making sure everyone on the whole team has all the education to make sure that patients are all treated the same way, no matter which part of the hospital or clinic they go to.
Right. And Hannah, I was just going to say too, to let everybody know, there was a situation the last days, and we just in our hall, we had our son, our substance use navigator, we had CPS, we had public health, right? Collaborating together, had just talked to the patient. This is going to be a good outcome. It's going to be a good outcome. And then social services, Marshall Social Services comes in. So we have our people, which feels really good for us, because
awesome.
We can't manage everything, and we and the communication is improving between all of those different organizations that just come together. So so that, I think, is going pretty well.
Awesome.
Yeah.
Thank you. All right, we are going to move to our next topic. We're going to talk about harm reduction implementation. Sherry, I would love to hear from you. So tell us a little bit about your naloxone distribution program. What has worked well? And do you have any examples of a success related to naloxone distribution?
Absolutely. So when we implemented as project coordinator for Pomona, our whole California Bridge MAT program, we started our program March, I think the first week of March, and the second week of March is when we went on the lockdown. Nobody could go anywhere. So we had no patients. So I was scrambling to do something else. And Josh Lefting with California Bridge, who was an excellent resource, taught me how to order the naloxone. We now, since then, have a naloxone toolkit. And I don't know if maybe Amy can put that in the chat. That is instrumental. It takes you step by step on how to order the naloxone for your facility. So prior to that, Josh walked me through, gave all the information that's in the toolkit, and we sent that. It comes in less than a month. So it's something that you can implement immediately. There it is. Thanks, Amy, so much, because that is in detail of how to get your naloxone distribution program started. And with the guidance of, the emergency room leadership, my director, my medical director, again, we did a mandatory module that went directly to the California Department of Health video. It was a Google form. They did a competency, and again, it was mandatory for the nursing staff. So anybody can, go on there. That's what we used. Again, just a mandatory requirement. But the best part of it was once they had this freedom and independence to give naloxone without an order, we as nurses have a hard time not doing something without a doctor order. So, that was one of the barriers, definitely, to review. The biggest barrier is you do not need a doctor order. That was kind of the holdup. A lot of nurses, our education went out. They did the education, but they didn't remember that little important piece. We can assess and we can provide naloxone to any high-risk patient.
So just real quick, since I'm not sure how many people that are attending know exactly how it works, can you walk us through step by step what it looks like for naloxone to be distributed from the emergency department?
Okay, so our facility, our hospital chose to put it in the Omnicell because our sons are nurses. And so what that is anybody that's high risk don't need a doctor order. A doctor already puts it in there. They may make a note, but we can't put it as an order because that means you're administering the naloxone. So this is definitely a discharge. So, that was another piece of education. But once the nurse can assess the patient, if they're anybody that's on opioids, anybody that's using street drugs, it is their clinical judgment that they can just go to like a Pyxis, an Omnicell. There's a standard paper form that they fill out, put a patient sticker, put the serial number, leave it in the paper in the bin. They get a bag with the kit with all of the education, and they disperse it to the patient or family member. At RED, anybody, even if they're not a patient, can come in and receive it. So even if somebody just comes up in the lobby and says, hey, I need a Narcan, our nurse can get it from the Pyxis, Omnicell, and just write the form and put it in a box. It's very simple. There is, nothing else I can say except once you get that process and everybody knows. We've had some other staff nurses want to have it for their medical emergency kit. We had somebody who is a soccer mom nurse. So she goes to, soccer, soccer tournaments and things. And she's like, hey, this would be great in my emergency medical kit for, when I'm out being a nurse. So again, we didn't have any restrictions. Anybody can have it. And anybody, without a doctor order. So I strongly suggest my lessons learned are, just reminding our nursing staff that they do not have to have a doctor's order, because I think that was the biggest barrier. Since then, it's been amazing with trust for our patients. You talk about decreasing stigma. Some of our nurses were not comfortable in the beginning. I'm distributing it, they felt, great, I'm doing this. But with the stigma, we also said, you know what, we're saving somebody's life, right? It's a sister, it's a brother, it's a husband, it's a mother, it's a father. And because we have such a big, huge ER, we were giving education one-to-one in the emergency room when one of our nurses say, oh, great, now we're giving drugs, more drugs to drug addicts. And fortunately, there was another nurse that came up and gave a testimonial of her own family member who overdosed. And I think once that was said and that carried out through the ER, people are champions that you don't even know that really want to provide safe harm reduction care. And to be honest, Hannah, my team did not know what the term, and some still don't, nurses at our hospital, harm reduction. So, they don't put the pieces together. Nurses are very busy and have to know so much, you need to know code blue protocols, you need to know STEMI protocols, you need to know stroke protocols. So again, texting us and making that available, and they know if I'm not working, we don't answer the text, we'll answer it the next day. That kind of relieved their pressure that, okay, I don't know enough to know about this, but hey, can you follow up? I left a patient for you. So, again, it's just meeting everybody where they're at, not only our patients, but our nurses. There is no judgment and no stigma with them if they don't know, because a lot of them did not. This is the first introduction when I told them about what harm reduction is. It's part of a whole system, whole process. It's not just giving out the naloxone. It's, it's the talking to patients, using the first person language. So again, that's, implementing all of that and finding champions. Our pharmacists were great champions to distribute and go to other floors. We asked for anybody interested on other floors that wanted to start this project, and always finding clinical champions on your nursing units is a huge asset, because you have somebody that really cares. And actually there's a lot of people that were going to school that wanted to make this their project, and that they wanted to help distribute it on their floor. So that's definitely another way to go, is if there's somebody in a BSN program or master's, we told them, here you go, here's you can educate your staff. So it kind of grew momentum once we got it started, but it's very simple, very easy. I need to go back to that toolkit. I can't explain more of how simple and how easy it is to follow those steps, and you'll get it within a month. Honestly, you'll have it, and you just need to make your process. So it really works. So our team, like I said, we gave them a little script because they didn't know how to talk to patients about it. They didn't want to seem that they were overwhelming the patient. So they just say, hey, I want to keep you safe. Here you go. Here's the naloxone. Do you know how to use it? Our nurses were surprised. Most of them didn't know or had it at their house. So it wasn't as new and innovative as they thought, talking to the patients. So did I answer your question, I hope?
Yeah, thank you. No, we've seen the same thing at Marshall with our naloxone distribution program. It's really easy. We actually don't store it in the Pyxis or Omnicell. It's actually in a cupboard in a safe, locked location, but the nurses, anybody who is competent can go grab a kit and hand it to anybody. You do have to just say how many. We don't even have to write down the lot number. That's recorded in a different way, but we just write down how many we've handed out, and it goes to the patient, a family member. They don't have to be registered. It's a really easy process, and we've actually had patients return to our emergency department who were reversed at home from the naloxone we handed out. And that is the most incredible thing, to know that something that we did, an intervention that we had to give them that safety net at home, potentially saved their life. And that's just a really cool thing to be a part of, and to know that we're giving people those tools so that they don't have empty hands at home if they're seeing their loved one overdose. Yeah. Thank you for sharing, Sherry. We appreciate that. Does anyone on the chat have any questions? I want to pause real quick before we cover our last topic. Are there any questions that have come up that you want us to address in the moment? Could be harm reduction, could be something else that came up. Will we get this slide deck? The one from today's presentation, Dawn, or great funds for? Yes, this presentation will be recorded, and so you'll get a link to the recording from this presentation, and then you can reach out if you want the slide deck in particular. We can discuss how to get you what resources you're looking for. Does Bridge give funds for the naloxone kits? I don't know. Sherry, do you want to speak to that?
And when you apply for the naloxone grant, it's through this state of California, so it is free. So you do not need any money. And it's all supplied by Public Department of Health services. So you just apply and they will grant you how many, whatever you put down as the amount. So definitely you can apply. And the refills, I see Artenis the same way. The refills, you do the same thing. You reapply for the grant, and it's Amy has put it in the chat, the link. So everything is there that you need. Somebody also asked, what do I put in my kits, naloxone kits? We put alcohol pads and we put hand sanitizer. That's what we use, and put it in a bag for our naloxone kits. We don't give out anything else.
Some facilities will add face shields for rescue breaths in their kits as well. That kind of depends on the facility. All right, let's move on to our last topic. We're just going to talk about some big wins that we've had at our individual sites. Jen, do you want to start? I know you shared with me a really cool story when we were talking before. Do you want to tell us a bit about any big wins that you've had?
Sure. Like I said, I was going through our most recent charts of patients who had gotten Suboxone here. And there was a patient who had had a motor vehicle accident probably a year prior. And he had taken pain medication and then, gotten addicted. And he was on the program where he was getting the therapy sessions and was on Suboxone. But he came in as a patient as an overdose, and the family had used the naloxone on him at home. So he was able to come in, get the treatment for that acute, situation, but then also get the education and further connect with our son, which, when you understand the pathophysiology of this, it's going to block, the addiction properties, but not deal so much with acute pain. And so that's where we get into, we really need to make sure that patients have all of the resources they need to stay on their program, but also deal with acute pain situations that come up. So, in this situation, I could see where the son had written notes about how to connect him. Not only, of course, making sure that he's working with his clinic, but getting him other resources to make sure that it's going to be successful for him. And like I said, in a few other chart reviews, I noticed just so many great notes from the son, connecting patients with resources, who she has spoken with in the community to help them. So we can just see, the process is working so well in that way.
Awesome, thank you. Christine, do you have any big wins that you want to share?
Yes, first off, I'm excited about the naloxone. I believe that that's one thing I need to add to our toolkit too. So I'm learning a lot today as well. I wanted to share a personal experience that I had, and then if we have time, I can share one on the unit also. But back before California Bridge was California Bridge in our ER, I was asked by a friend to go pick up her son, who was a heroin addict and he was going through withdrawals. And so I pick him up, and I had never seen what I saw. And I'm sure that those of you that work in the ED see this a lot, but I hadn't before, and it's really painful to watch them go through this. It's a very, very painful experience for them. And so I bring him to the ER, and they give him fluids, but really honestly, they offer him ibuprofen. This was back before, and it was really a sad situation because I had to take him and drop him off, and I knew in my heart that that boy was going to go in use right away. There was no other choice for him. He was in so much pain. So I was kind of like, really? It was just, that was the first realization, like, we don't have anything for this. It was awful for me to experience. Well, about a year later, this young man overdosed and was brought to the ICU, was in the ICU for a week. He lived, he's actually, it's a really good story. But once he was done with that scary experience, he started buprenorphine. And I will tell you, since with CARES and with our clinic, and I have not seen anything that's been something less than a miracle. This was, he is so productive. I could go on and on about what he's doing these days. And it is just, so the before and after is just so big. And I can't even imagine how many lives I see it here. I see it here with the moms that are coming. They actually have a chance to keep their babies. Otherwise, they didn't have a chance. They were so grateful to have some sort of treatment. It's just, I see it here. We had a mother here that came in, had previous CPS involvement, and she was kind of unwilling to go to a treatment program at all. But we talked to her, my director talked to her, and she ended up agreeing to go. And so she went, and we just got, this is months ago, and we just got news back from the family thanking us up and down that they got their daughter back. Not only through her treatment with buprenorphine, but through an extended program that was able to keep now her new baby and her together, and actually, it turns out, her whole family. So what a good, I mean, we're having an impact out there. And so I see wins, and I love to hear about wins too. I don't know about you guys, but I love to hear it, because sometimes, you kind of pass the wand and somebody else is following up with these. You don't hear that all the time. And so to be hearing back from this family, or to see good friends of mine have their son to hold and love and experience as an adult is just, it gives me chills. It's just like amazing. So good stuff, you guys.
Thank you.
Yeah.
Sherry, what about you? Do you have any big wins?
I'm gonna share, like Christine, it's personal with one of our nurses. Her son was struggling with opioid dependence for 9 months. She was very, I'm asking for a friend. You've seen that, the meme of asking for a friend. So we had a lot of conversations throughout the months. And never knew why. She never divulged because of the stigma. She didn't want her coworkers knowing that her son was, using drugs. She always had it very well put together. All of us have our what we portray to the world, right? And then what's going on at home. And so her stage, we knew nothing that was going on. Just a few weeks ago, I did receive a letter, and she sent it to actually me and our emergency room doctors and our emergency room director, just stating that she believes in California Bridge, the MAP program, that this completely changed her life, that she never divulged. She felt stigmatized, her and her son. She would never bring him to the hospital if he overdosed. She would go to a different facility. So that way nobody would even, suspect. But, things come to an end, and she brought him in, and she could not believe the understanding. And she said, before this program, she wouldn't even have thought to brought him. But because she started seeing how all the other patients were treating and how the nurses' attitudes were changing, she felt that she felt safe. And, everybody's like, do you have Narcan? Let's text Sherry right now. I'll tell her to call your son right now. She was amazed, because she said that she was embarrassed. The stigma was so bad prior to this program. So, all of you that are working, just within your coworkers, your friends, like Christine said, substance use is what, 1 to 10, 1 to 12. So look around you. Chances are somebody, and with trying to decrease the stigma, doing harm reduction, normalizing, just like, Tana said in the beginning, it's just like hypertension. It's just like diabetes. It's chronic illness. And the one thing, definitely I told this nurse was, it's not about willpower. He probably has more willpower than we'll ever know. because, I know, I say I'm not going to eat cookies, right? And I'm, the first one to say, oh, what kind is that? Let me try it. This is not the willpower. And when she said that, she said something, when you said the willpower, like I kept thinking he wasn't strong. He's not a strong person. He's, I need to, protect him. I need to, she was the enabler. But that kind of hit home. So really, whenever as a nurse, you're talking about substance use as a chronic illness, just remember listening, because this might definitely be somebody in your circle that you don't know. And that was this nurse. She was, in the circle, and we did not know. And I'm happy to report that we linked up her son to treatment. He's been, on his treatment for about almost, I would say, 3 weeks now. He's doing really well. She changed her attitude immensely towards the whole situation, and it's working. So, that's a true success. I'm not going to say everything's success, but that is just with our own nursing department. You'll never know who you're talking to and who's listening. So I really just remind everybody in your nursing circles, because the more we normalize it and the more we accept it, it definitely can change the outcome of not only your patients, but of those around you, right? Your family, your friends, your coworkers. So that's kind of the story that lingers, because this definitely hit home, and we didn't realize how much it was going to hit home to our own hospital family. Because out of 700 people on staff in a day, that's, there's chances are there's somebody who knows, somebody who is using drugs. So that was a huge win for us, is just, putting it together. We're helping our community, whether it's your hospital community, your physical community, we're changing it. So, it's one step at a time. It doesn't come overnight. That's probably the biggest win is, you're in it for the long haul. This is not a race. You're in it for the long haul, and, just one step at a time. You don't have to get everything done immediately. And that's what we've learned with this program. We wanted to go out running, right? Hurry up, let's do everything all together. But you can't. You have to take, your steps and go, make sure, you're targeting the most you can do for your patients. So, that's the story that I have, is you just never know in your circle who you're gonna affect.
Thank you, Sherry. Yeah, that brings to mind a recent circumstance that I had with a patient. A gentleman in our community actually called on the phone first because he was nervous about coming in and he didn't know where to go to get treatment. So he actually just called the emergency department, and the phone call got routed to me. And he was like, I'm having pretty severe withdrawal, but I don't know what to do. I've been treated, he said, I've been treated like crap there before. And he was really scared to come in because he didn't think he would get help. And I just told him, hey, this is what we do. This is how we treat patients who are in withdrawal. We get the medication to help treat the cravings and the symptoms of withdrawal, and then we're able to connect you with a longer term plan. So please come in and we'll help you. And he actually did come in a little while later, and I was able to talk to him, and he teared up when he talked about it. Just like he was so blown away by how the culture had changed at the hospital. And he was really grateful that he knew he could come there for help, and he could tell his loved ones that they could come and actually get help. So that was really empowering as a nurse. And I think that's been very empowering for our whole team of nurses in our department, that, when a patient does need our help, we have something that we can do, right? I know before, sometimes it was really challenging. And I think that's part of what maybe has caused us to develop feelings about someone checking in with substance use disorder, was because our hands were kind of tied. There wasn't really an option or something we could do to offer that patient. And I feel like our nursing team is like, oh, cool, you're checking in because you have opioid withdrawal. Let's do this. Like, they know what the process is, and we have a way, we have something we can do that will help. So that's really exciting as a team. And it's fun to see it firsthand when it directly affects those patients. So All right, I want to open it up for any questions from the audience. If anyone on the chat has any questions for us, we would love to answer them. And if we don't have the answer, we'll be able to point you in the right direction. So this is the free for all. If you have any questions, let us know. And while you're thinking about that, I want to ask the panel if there's any challenges that you're currently navigating. Does anyone have anything that the team is working on right now that's been a challenge?
Definitely.
I know what I'm doing is working on some education regarding stigma for our nursing staff. We've come a long way, but it's always a work in process, and we have a lot of new staff members. So we're actually going to be revamping our training on providing that culture of care and learning about those language choices and how our words matter and how that impacts our perception of patients. So that's what we're working on right now. What were you going to say, Christine?
Exactly that. Education, making sure that everybody not only knows what to do when they get a patient here, but also exactly what you're talking about, how we interact, our words. I can't wait to get them all going on all of that. So yeah, that's what we'll be working on. For sure.
Awesome. Sherry or Jen, do you have any challenges you're currently working on related to this work?
Well, I think right now at my facility, we're trying to get on the Cal Opioid dashboard for Compare, the hospital Compare. So we want to make the honor roll. So we're doing a lot towards moving that direction with opioid, usage in the hospital. So, that's kind of been a focus. So I'm really glad to say that our nursing education will be yearly. We've never had that before. So definitely we're going to, try to resubmit our application for the honor roll and just try to continue the education. Like you said, I'm just like no different, even as the California Bridge Sun program director, nursing education still remains a top focus.
Awesome, thank you. All right, let's see. Can you share the training for the nursing staff? Absolutely. I have a couple resources that we can send you today. There's a handout on creating a culture of care that has some really good tools for nurses. We have a nursing toolkit as well that you can access on our website. I'll make sure that all of those links are included in the post-event survey. But there's also going to be a module related to nursing education that you could implement on your, you could upload on your own LMS, and we'll share that with you as soon as it's ready. Okay, let's see. Sorry, I'm trying to scroll through the chat here. I work in a large academic medical center in New York. Wonder how to get administrative buy-in on the importance of improving care for patients with substance use disorders. That is an excellent question. Does anyone on the panel want to tackle that?
Yeah, I can talk to that or speak to that. I think when you're talking to your administrative team, you really have to look at dollars and cents. So if you can, put together some sort of business plan that states that if you have this program, you're less likely to see people coming in with overdoses, which can be, these patients may end up staying in your emergency department for a long period of time. And then also as the program kind of gets known in your community, that is a big thing. Like people were just talking about that there's less stigma. People are willing to come in, they're willing to come in and get their care for that particular thing, but also for just other, conditions. So it actually can almost be like a marketing thing. We actually have signs in our waiting room in our lobby that were provided by California Bridge, that say something to the effect of, do you need help with drugs? We are here to help you. And so it can help the community know exactly what they were saying also about the stigma, that we've changed how we treat these patients. And so it's like a welcoming, feeling for patients in the community. So if you can, figure out your business plan where it may be saving them some money with taking care of patients who, unfortunately, sometimes these patients don't have jobs, so they're not able to pay their hospital bills, you may find a way that you can reduce that.
Yeah, that's a good point, is showing the business side of it. And then in addition, just showing the evidence that shows that this is best practice for patients. This really is the standard of care, is to provide treatment in this way. So showing them some of that evidence might be helpful as well. All right, to clarify, to obtain the naloxone grant, you apply through Department of Health Services. We'll make sure that that naloxone toolkit is in the post-event email, and that has the link with all of the information so that you can make sure that you go to the right place to apply for that grant. All right.
Thank you so much, Tana. Thank you all for being here. I know we're at time. We just have a few more slides that have some contact information for you all. So Tana, if you want to move us to the resources slide.
Yes, absolutely.
Yeah, thank you all for joining us today. We're really glad you could be here. So we have opportunities for resources available on our website. We have a huge library, and we are always expanding this and welcoming feedback from you all of what resources you need to help you do this work. There's a QR code there, so you can scan that, and you know, through the magic of technology, that'll open up directly on your smartphone. And then there's also an opportunity to request technical assistance. So for some of those of you in the chat who are navigating some bigger barriers, or maybe even some small barriers, and want some insight, this is a great opportunity. You can reach out to us directly, and you know, we'll troubleshoot with you and help you figure out how to move this program forward, and figure out solutions for your specific sites. And we have a training coming up tomorrow, actually, another event, Boot Camp for Champions. So this is about youth and medication for addiction treatment. So the youth population is an unfortunately growing population of folks who use substances, and we really want to be able to show up for them. And so this is a great session between Reb Close and Sharon Loftapour, who are just fantastic clinicians, and they are just going to share some incredible knowledge with us tomorrow. And here's how you can get a hold of us. We have our website, an opportunity to join our newsletter, and we're available on Twitter and Facebook and Instagram. And our very last slide will be a contact information for the panelists. So again, a huge thanks to Tana for facilitating. Jen, Sherry, Christine, thank you so much for sharing your experiences and sharing the knowledge that you have gained, and, you know, being forthright about some of the challenges that you faced. It's really been fantastic to have this opportunity for sharing. So again, thank you all for joining us. We'll be sending out a post-event survey that has links for CME, and including some of the resources that were mentioned here today. So thank you all. Hope you have a great rest of your day.
Take care.